Group presentation, ECG Basic and Beyond. And today, amongst us, we have Professor Dr. Chowdhury Ahsan, sir. He will deliver a speech on EKGs for intensivist, case-based discussion. And as usual, before discussion starts, I'd like to request Professor Rafique Ahmed, sir, to say some words about Ahsan, sir, and then we proceed. I kindly request Rafique Ahmed, sir.
Assalamu alaikum. Good evening. Hafiz does not require introduction, well known amongst, I hope, all of you, but he is a professor of medicine and program director of cardiology. Beyond that, he is vested in Bangladesh, and anything related to Bangladesh, Hafiz is there. A true patriot and an academician. Hafiz, please start your lecture.
Thank you, Rafique, for those kind words. And so let me share some cases. And today we will make it very didactic. So let me tell you about this lady. She's 85 in ICU for last 2 days. I would request you to look at the EKG. Look at the October 10 at 5 a.m. and then October 10 at 1700, that means 5 p.m. So what we can look at, get out of these EKGs, what do you think? Because for the first EKG, they are concerned, but somehow they did not tell us. And the second EKG, they told us, oh, well, this is STEMI. We need to do something. Any takers? So let me tell you, this is interesting because I actually picked up this EKG in the morning, but they did not call us, so we did not jump. Then in the evening, they called us, and this was a patient with toxic megacolon, severe acidosis, hyperkalemia. And we just did a bedside echo to help them. And the LV function was hyperdynamic septic patient. So this is something that we see in the ICU that we need to work with them. And to make things worse, the troponin, of course, came positive, and that is sepsis-related troponin.
Is it due to increased pressure intra-abdominal?
Was that?
Increased intra-abdominal pressure?
Well, the toxic megacolon belly was dilated, but the EKG changes are starting from hyperkalemia, and as the hyperkalemia gotten worse with acidosis, the QRS gotten wide. Yeah.
Sir, what was the potassium level during the second EKG?
Potassium level from the first EKG was 5.6, bicarb lactate like 4.5. By the evening, potassium went to 6.9, and the creatinine worse, and then lactate went to above 10. So she's still struggling. I don't think she may survive, So this is interesting. Another patient, 76-year-old, hip fracture, and then came in. We get a lot of this, and a pre-op, and EF 55%. Do you see any problem? Because hip fracture has significant mortality. So we try to triage them quick, because if we don't, and they don't get hip surgery, there is increased mortality. So with this EKG, anesthesia was nervous. What should we do?
So the ECG that is that appears on the screen.
There is a right bundle, and there is a right axis. And if you look carefully in the lead one, there is a P wave, but very long PR.
Yes. And
so
I
just wanted to mention this, that in the EP world, they call it block. but there is no block in the conduction. It is a delay. So delayed right bundle, then delayed left posterior fascicular block, and then prolonged PR. So how you tell the anesthesiologist that the patient will be okay or not? EF normal, and there is no major valve problem. Rafique bhai, any comment?
No, I'm having some technical issue with this. I can't see your screen for some reason.
Oh my God.
I could, but I think I messed it up. I pressed the wrong button. So you proceed. Let me find.
So we actually, Aziz bhai, do you have any comment? Aziz bhai is sleepy.
Yeah, no. My question right now, yes, it's prolonged PR, right bundle. I mean, left bifascicular block. There's question about whether they might progress further, and anesthesia is duly concerned. That is true.
Yeah. So I think it is. I don't know what Rafique bhai will say once he sees it. It is a issue about whether you put a temporary wire or a transcutaneous spacer on standby. Patient did not have any syncope, no dizziness. So we ended up putting a temporary wire because anesthesia was not comfortable. And then this, I'm just going through a couple of cases and then I'll give you an overview. This patient is in the ICU and very sick, metastasis, prostate CA, and shortness of breath. There is pleural effusion. And this happened in the EKG, when they did the EKG in the ICU. So my question is, how you read it and what we do?
I think there's some ST elevation there, inferior lateral.
Yep.
And posterior involvement possible. Okay.
Yep. And then also there is clearly AV dissociation, complete heart block.
That is correct, yeah.
So my question is, not everything is same in terms of what we do, because this patient is metastasis and patient was categorized Cat 3, which means that no resuscitation. So it was tough. So I'm sure that in Bangladesh, you also see this. Sometimes it is the futility of care that even if you see this, you may not be able to offer anything.
Now,
another
question I have.
It is better to accept. Any comment on this? Any faculty from Bangladesh that in a situation like this, when there is a terminal care and the ICU doctors are calling you, how you tackle this? Because our choices are very limited.
I think I would look into one thing. What's the longevity of this patient? What's the prognosis? Okay, the prognosis is more than a year. I probably go ahead and do it.
So I am not very familiar with but we need to know more about the cardio-oncology. And if the oncology prognosis is poor, patient is on chemo, and the platelet is 30, then our hands are very tight, because we do anything in cardiology to improve survival and relieve symptoms. And patients' survival is already compromised, and we cannot make much better of the situation by this. And it is case to case. Some patient may want something to be done, and some probably would not want anything, but we need to get an engagement with the family unmet, and then concede defeat and agree with the hospice care. So in general, in intensive care, we have this problem mainly with arrhythmias. However, there is a big picture of encountering ischemia, infarct, And sometimes what it looks like, the ischemia and infarction mimics that make the ICU intensivist very concerned. And a big thing is electrolyte imbalance, hypoxia, acidosis, and also / sepsis. Sepsis can do a lot of things. And it is not just one item of arrhythmia. It can be a combination of all of this. But I would request you to look at the clinical context before we interpret the EKG. I think we should not interpret EKG in the ICU, and for that matter, in anywhere, in isolation. Only time I read the EKG in isolation when I'm taking the board exam, because in all other cases, all other situations, our biggest information source is available next to EKG, which is the patient. And it is important that we interpret the EKG in the context of the patient and make, as Rafique Bhai always says, make a differential. And your working diagnosis on the EKG and a differential diagnosis, and then make sure that we don't panic and use one thing for sure in EKG interpretation. If you take into consideration of the patient's condition and you have the EKG and you can check tachycardia or bradycardia, wide complex or narrow complex, regular or irregular, and the pattern recognition, and you know the patient, and you currently have point of care ultrasound or echo, most of the things you will be able to figure out. Having said that, if I don't say anything about this EKG, what will be your diagnosis?
Okay, is this the next one or?
Now, this is a patient that I'm just showing you the EKG. The
Now,
EKG.
the one, can I just ask a question about the one before?
Which one?
The one that you first EKG.
Or the one that I asked you?
Yes. So
This
that
one?
patient, was the patient hemodynamically unstable?
No, this is, I'm not sure, because you probably now can see it now. This is a patient with, on the right side, 76-year-old.
Now the one that 80-year-old with inferior MI.
Oh, okay,
with metastasis.
Yeah.
Patient was very sick, right?
Very sick.
Hemodynamically unstable.
Blood pressure like 90, 50. Hemoglobin low, platelet low.
Okay. So I want to mention something about this patient.
Yeah.
I think there is a general tendency amongst us. I can always say, well, let's intubate the patient, let's put them in ICU and do everything. But the question is, that's the easy path out. And I think that's happening to a lot of patients. Patients who are going to die. And we have to make that hard decision.
Yep.
Before we intubate that person, before we put tubes, we sit down with senior member of the family or the responsible person of the family and ask them what they want us to do. Instead of being a reflex that let's intubate and let's talk, because once you intubate, it's very difficult to extubate. The other part is the difference between America and Bangladesh is that we have health insurance here. So not a problem. But if you have a school teacher who comes to this in this kind of scenario and you end up intubating the person, that family is going to go get bankrupt in Bangladesh. So we have to keep that in consideration. And please, the younger generation of doctors, our generation is one, but younger generation, I hope you get into this and take the social responsibility about the patient care. Thank you.
Yeah. Thank you, Rafique. That's a word of wisdom. And it's very, very important that we take a fair look at the patient and then take the wise decision in a broad spectrum. I think it is okay to tell them that the temporary wire will not solve the problem. It is okay to tell them that I can do echo and cath. I can open up an artery, but in the bigger context, this is probably futility of care. So this patient, I'm not giving you any information. If the EKG take gives you this EKG, what will cross in your mind? You want to know about the patient. And you want to know where is this patient, how the patient came in. I tell the residents and cardiology fellows that please ask 3 questions, like Tolstoy, Leo Tolstoy, that who is the most important person in your life? The person next to me. What is the most important time now? And what is the most important thing to do? The work in hand. For hospital, 3 questions. Why you are here? Why the patient is in the hospital? And second thing, is there any mileage? Meaning patient has been here before. And third thing, any cardiology procedure done? EP, device, stent, bypass, anything. That will be huge, which is basically your HNP. This patient in the ICU.
Is he on the ventilator?
The patient is on the ventilator, came in with shortness of breath, altered mentation, and progressively deteriorating. EKG is worse. And then this patient is DKA with acidosis hyperkalemia. But this patient troponin was positive. In fact, this patient was activated from the emergency room for a STEMI because of the V1, V2, V3. Any clue why we did not take to the cath lab?
That's my question right now. Look at the V3, V2, the ST elevations starts way early.
Yeah.
In the QRS complex even, not at the end. So it may not be a STEMI at all. It could be just intrathoracic pressure is very high.
That is right. And then look at the AVR.
I have seen this type of patient.
Yeah. And this is typical.
You talk about this shoulder down, shoulder up.
Yeah.
Can you just... I saw this and then I said, well,
yeah. And when as Rafique bhai pointed out, when there is the milieu that this looks like, oh, there may be something else. And then you see the patient, then you see the glucose, then you wait for then you check. But I would request you, this is a pattern recognition. This EKG is so good that you should start giving medication for hyperkalemia, such as calcium, etc. Not wait. So having said that, and this is the reason I put this EKG, and my question to Rafique bhai, the EKG pattern on the top and the EKG pattern on the bottom, will you make any difference in terms of pattern recognition? But I'll tell you, life is easy if the patient on the top is a patient from Thailand, came to Los Angeles and had palpitation, then this is Brugada until proven otherwise. And the patient, and the bottom one, if the patient is a non-insulin dependent diabetes and had previous DKA, coming with belly pain, rapid breathing, mentation altered, and this EKG. The clinical context, both are different, but pattern also can be different. Rafique bhai, any comment? But I think we are not cheating. We need to take the clinical context to interpret the EKG. Rafique bhai.
Anybody else want to comment?
I mean, peak T wave we can see, and then progression would be.
Yep. So I think this is very important.
Low P wave and prominent T wave, in this context, hyperkalemia is likely.
Yeah, exactly. And Wadud, thank you. I just showed this one also, that I don't know you saw this, that the clinical context and the pattern recognition is very important. And ICU doctors and us, cardiology, we need to work together, and they need to convince us, we need to convince them, and we provide the care. So I want to tell this group, those who are young and also involved in the ICU care, do not feel intimidated by any EKGs. Find out, is the EKG heart rate? Is it tachyarrhythmia? Is it narrow or wide? Is it regular or irregular? Or is it irregularly irregular? And then pattern recognize. And then see who is the patient. What is the patient's hemodynamic? Comorbidities. Can I offer a differential diagnosis? And also, what is my working diagnosis? And then what options we have. And when you talk and think that way, I think you have less chance of missing a major diagnosis. You will be okay. So with that being said, this patient is in neurosurgical ICU, and the neurosurgical ICU attending is very concerned about this EKG and called cardiology stat, because the neurosurgery attending is new and got worried about this EKG. What do you say?
Very deep QA inversion, AFib going on. Okay. Most likely.
So this patient had
Apparently,
89-year-old found down neuro ICU subdural.
subdural. Yeah, independent hemorrhage.
Neurosurgery wanted to do craniotomy. Trauma attending was not comfortable with this EKG, and they put some block in terms of proceeding to the OR. What do you say? Proceed or stop?
89, we need to consider what's his clinical status.
This is it.
Quality of life.
Systolic blood. No, otherwise he was fine. He was playing golf 2 weeks ago.
And if the
So,
blood work
Ahmed,
is okay. Yeah.
I mean,
Yeah.
one of the things, if you look at subdural hematoma surgery,
Yeah.
it's not a major surgery.
Yeah.
You are just drilling a hole in the bone.
Yeah.
But if you don't do it, what will happen?
Yes. So
That's
I
the
told
difference.
them that the uglier it looks, it is less likely coronary. And then forget it. I said, do not stop, proceed to neurosurgery. And on the way, I said, if you want to talk to the anesthesia, I'll talk to the anesthesia. We throw an echo, and echo was fine. I said fine, but there was some apical ballooning. So this is classic for stress cardiomyopathy, but we cleared the patient. So this is very, very important that we don't put, and sometimes the cardio, it happened to my father, had this EKG changes, hip surgery. So I'm very emotional about it. And I actually had Professor Maximulok go to that hospital and then clear. Even we said that we take the responsibility. He did get the hip surgery done because he has a right bundle. And that's why I am very particular about right bundle branch delay, not block. Because my mom called me like saying, hey, your dad has blockage. I said, no, that's different blockage. So now another thing, patient is admitted in ICU and then had this EKG.
Sir, can I interrupt for a second?
Yeah.
The earlier ECG, the previous ECG, where there is
This one.
cerebral, yes, and
Yeah.
apparently AFib. So when will you advise to start anticoagulation?
Absolutely not. First of all, there is subdural. If it is in my family, it is always a debate. What is more important, heart or lungs? I'm the cardiologist. My wife is a neurologist, and the kids are in the middle. Which is more important? Both are important. But when there is because if we do heparin, as Rafique Bhai was pointing out, it will make the subdural worsen. And if the subdural worsen, patient dies, the game is over. So
No, sir.
we do not give any heparin.
No, not now. I'm saying that after surgery, when will you start anticoagulation? Because this patient needs anticoagulation.
Okay.
What will you advise?
Okay.
Can I answer that question?
Before Rafique Bhai, you say there is a trick here. I did not go into that. So Tushar, there is an indication for heparin maybe, But can you tell what is that indication looking at this EKG? It is not the teen version. This is not type 1 MI. If it is not type 1 MI, meaning no plaque rupture, no plaque erosion, no plaque nodule and activation of the coagulation and the platelet activation, then there is no need for heparin. But this patient has AFib also. So you can argue about that AFib later on. But for coronary, there is no need. This is not the type 1 MI that we are dealing with. So there is no indication for heparin.
I was telling because of the atrial fibrillation. I was not telling about the coronaries. Because this
Perfect.
patient has atrial
Absolutely.
fibrillation.
And you meet my expectation, because I'm glad that you did not miss the AFib. Perfect.
No, sir.
Okay,
So
let me make a comment on that.
Yeah.
So let's take this patient with AFib at the highest risk.
Yeah.
Risk of stroke in a year will be 10%. I just calculated daily risk of stroke is 0.027%. So if I wait 100 days without anticoagulation, I am taking 2.7% risk of stroke at the highest category.
Yeah.
On the other hand, if I give anticoagulation within 3 months of subdural hematoma, the risk of bleeding is extremely high. So what we do is we wait with anticoagulation, and then we get clearance from neurology before we decide. And the other thing that we are doing is that in this kind of patient, they are at really high risk of recurrent. We consider Watchman device, which is an expensive proposition for Bangladesh. But even if you don't anticoagulate, as I told you, in 100 days, I'm taking a risk of 2.7% at the highest risk category. So we should not get carried away with anticoagulation in this kind of patient.
And Tushar, just to let you know that there is a lot of variation among neurosurgeons. The patient gets subdural evacuation, patient gets better. We do a repeat scan, as Rafique Bhai said. Some said, okay to start after 2 weeks. Some say 4 weeks, some say 6 weeks. We go by what they say. But Watchman will be a very attractive proposition, Rafique Bhai.
Another thing
so this patient with the ICU and came in with, I think if I remember, that patient had a transplant, and patient is relatively young, no structural heart disease, and developed renal failure. And then this EKG found. Any idea what the medication was?
Severe hyperkalemia, just sinus wave, I think.
Possible, but potassium actually came normal. So this patient was taking flecainide and developed this. So because of the renal failure, developed white QRS, potassium was normal. And then structurally normal heart, paroxysmal AFib, was taking flecainide, but gotten this problem. So sometimes it is important to keep our mind open, take proper history and find out. We knew that this probably is flecainide because it was in the list. Now, this is a patient, it's a very interesting patient, 59-year-old breast carcinoma, waist loss, and losing weight, and then came to the ER with hypoxia, and then blood pressure was soft, borderline 85, 90, they gave fluid, and this EKG. Any suggestion?
What's the JVD on this patient? High?
JVD is elevated.
Yes, the patient probably, we need to do quick echo on her to make sure there's no fluid around the pericardium. Yeah.
So
tamponade, basically, most likely. Alternance.
Before you go to the echo,
yeah,
can you please explain to the audience more about this ECG?
Yes.
Yes. There's electrical
alternance.
Yes, QRS, you see that, amplitude is varying. It's probably alternate, in the fluid floating. There's different, explanation of that. But definitely we see the QRS alternance. If you carefully, and actually he actually marked those things on the red arrows. So that clearly suggests that There's few situations you electrical alternates. There's one of those tamponade. It's like large pericardial effusion. Not necessarily they have to be on tamponade, but another one, most commonly severe cardiomyopathy and distress cardiomyopathy. Also, you can see that.
Yep. And any comment, Aziz bhai, in terms of QRS alternates versus total alternates, like whole PQRST also gets changes, like really swimming the heart. That is more characteristic of
That is correct, yeah.
Pericardial tamponade. So interestingly, this patient had an issue because there was mediastinal compression, like a SVC compression. And what happened, patient was not seeing any preload because of that. And on the other hand, there was large pericardial effusion. I will request you to see that the RV is not that dilated. We did the decompression and rapidly patient developed this. The RV got humongously dilated. And this is actually known. And we had to support the RV because what happened that with the decompression, there was sudden surge of flow and RV got dilated. We had to give the RV support and then stabilize. And we published, there was an evolving EKG changes for the RV. And this is typical post-pericardiocentesis syndrome that sometimes can be catastrophe. That's a very, patient actually survived, then got the chemo and the tumor shrunk and then went home almost 2 weeks later. So this is another interesting case. This patient was getting admitted to ICU, alcohol, liver cirrhosis, had a cardiac arrest, and then coughing blood, and then lost pulses, CPR, and then ER called us because there was clearly ST elevation in lead AVR and precordial ST depression. They were worried about left main ostial LAD. And they called us. So what to do? And the ICU says, so you're going to take this patient, we'll just intubate and we'll be with you. So now it is an ICU and CCU interplay.
It looks like STEMI mimic. Because of tachycardia itself.
Yeah.
And question right now, let's see. You can see some situation.
So good thing that we still have about 50 people online, which is we're making. So thank you, Tushar. Great efforts. At least we did half century.
It was 55, now 50.
Yeah. So any comment? Anyone? What you do? Hemoglobin came out low, and this is the hemoglobin came out low. We gave blood transfusion, intubated, corrected. We did not take the patient to the cath lab because what are you going to do? Cath lab is not a photography lab because platelets low, alcohol, and then after stabilizing, the EKG got a lot better. But I was cheating a little bit because I did do the echo. Echo actually was hyperdynamic LV, almost cavity obliteration with the echo. That tells me that unlikely that somebody with left main presentation with ACS or STEMI will be doing LV hyperdynamic. It's almost impossible. So, and here is the, thanks to my fellow, it looks like he did upload the echo. So look at this. LV is almost hugging the walls, I call it. And there is a little bit of LVH. So
Needs
we
some more
did not,
fluid.
we resuscitated,
Yeah.
and then patient did okay. And this is another EKG. I thought
Was
Rafique
it
bhai
due
may
to,
like this one. Any question on the previous one, Tushar?
was it due to AF that led to in presence
Okay.
of
Okay, so let me explain. I don't know how much time we have, because the overall, this was a multitude of problems. If you look at severe anemia, hypoperfusion because of hypotension, patient
Hypovolemia.
has LVH, and there is global subendocardial hypoxia that can give you this. Basically, when we talk about left main ostial LAD, we are talking about global ischemia, right? And that can be ischemia due to coronary occlusion. It can be global ischemia because of other problems. We learned this from the neurology. Remember, they call it watershed infarct. Sometimes when you get global hypoperfusion, you can get global the watershed infarct in the stroke world, and it became like reversible. And these later changes are also associated with, there is significant LVH in the EKG, as you can see, which was confirmed by the echo. So it makes sense if you put it together.
So this may be the combination of atrial fibrillation with concentrating LVH, and the increased rate resulted in rate-related ischemia.
Yeah, and as you pointed out, that tachycardia mediated ST changes are very well known because of the subendocardial ischemia.
You know, I have a feeling on that this patient did not have AFib. Patient is severe anemia, hypovolemia, and an acute clinical situation created the AFib. That might be secondary AFib. There's possibility.
No. The rhythm was AFib.
No, I mean, I'm questioning about, did he have previous
Oh,
AFib?
I know. Yeah, you're right. Yeah. Ultimately, the patient became sinus. Yeah.
Okay, I think secondary AFib is secondary. Yeah.
Yeah, it is a. I don't know whether there is a such term, but we see that often. Acute pancreatitis, acute appendicitis, subdiaphragmatic causes of AFib, which are transient. And then there is above diaphragm cause of AFib. Sometimes we see that with PE and AFib, right? And then the AFib resolves. So this one, I don't know if Rafique is still there. This is a bacteremia patient, and then patient developed this, and there was no previous right bundle, and this is a new right bundle, and you can comment on the rhythm, but we were called in. So are you concerned? That was our consult question.
And
so what was their concern?
Because it's a new right bundle.
Yeah.
And the
well, I mean, I look at the clinical scenario of the patient.
Yeah.
I mean, by this ECG, if I gave without any history, I'll not care much about it.
Yeah.
So why should I care about it now?
Yep.
Unless the history tells me something.
Yep.
That will be my view. It's new right bundle. So what? One day I may develop right bundle branch block. If I become tachyc, I may develop right bundle.
Yeah.
But the question is, am I having any other symptom related to that?
Yeah. And this bacteremia was 4 out of 4 blood culture.
Yeah. Okay. Anybody else have any comment?
So I actually did a TE, Rafique bhai. It was aortic root abscess.
Yeah.
So this is very important to recognize, and clinical context is very important. So let me, I don't know how much time we have. Let me.
Hafiz, can I just stop you? So Tushar asked this question about anticoagulation because elderly gentleman had AFib. Next patient, very sick patient, had AFib, and this patient had AFib. And then we get patients like this, and then the question comes up: do this patient need long-term anticoagulation? Because you have to make a decision. And my practice has been that if somebody comes very sick to the hospital, never had AFib before, it develops AFib, a lot of times I'll give them short-term anticoagulation. Yeah. And then I make a decision that this AFib was due to the sickness itself, and then stop anticoagulation. Is that your practice?
Yes, and but this is so important. Let me tell you another very important thing. This is really close to my heart because my wife's cousin's wife, who is very close to us, was AFib, and some reason somebody stopped. When we stop anticoagulation, particularly DOACs, there's plenty of literature that there is heightened thrombogenicity after the stopping. So first, the question is, should we start? And then second, should we stop? So if we are starting, then explain the bleeding risk and ischemic benefit. But also we are obligated to tell them that there is accumulated risk of bleeding, right? So if we do start, please also equally think before you stop. And situational AFib, as Rafique Bhai pointed out, patient comes back to sinus, we can do a monitoring and see whether they recurs and then do the CHADVASC and go by that. But there is an option for short term. But if we do cardiovert, then it changes. Then you need to give at least 4 to 6 weeks of anticoagulation because of the atrial standing with the cardioversion, and the thrombogenicity is high, at least in the first 2 weeks. Any question on this?
Sir, my question to both of you is that if someone with 75 years old man come with first time, as Rafique sir said, RTI, and develop atrial fibrillation, no documented atrial fibrillation before that. That is the first episode. So if we go by guideline, we have to continue the anticoagulation. And if we don't continue anticoagulation, what is the legal safety margin for the physicians in your country, not our part, in USA? How you can stop the anticoagulation? On which ground?
Okay, so first of all, Tushar, I wanted to point out one thing about you mentioned about guidelines. The guidelines are guidelines, and there are many small prints in the guidelines. But nobody will argue that for any patient with the AFib question, you need to look at the patient and the CHADVASC, because that's what we have in terms of this. I don't know what Rafique Bhai's comment is. And also look at the valvular heart disease like mitral stenosis and significant mitral stenosis, or patient with hypertrophic cardiomyopathy, or patient with thyrotoxicosis, for example. Some of these entities are beyond CHADVASC, and it comes often in the board because they will give you hypertrophic cardiomyopathy and AFib, and CHADVASC is low, but it doesn't matter because CHADVASC doesn't apply. And non-valvular AFib, CHADVASC was applied. So mitral stenosis rheumatic is so high, the CHADVASC doesn't apply there. Having said that, the rest of the world will do the CHADVASC and then see the AFib. Can we do at least short term, or are we committed for long term? And then you equate the risk benefit equation. One extreme example, I have a patient who is 89-year-old, mild dementia, fall risk, and checked by the physiotherapy, occupational therapy. And we negotiated with the family that this is high risk for fall and bleed. Therefore, we opted not to. But by book, this patient requires the anticoagulation. Does it answer your question? Maybe partly.
Yes, sir, partly. I ask Rafique sir the next part. So if you stop anticoagulation after starting, so what is the criteria for that? And if somebody sue a physician, I am there for the anticoagulation category and stop that. So what is the physician's say on that?
Okay.
The
So, I mean, I'll give you two scenarios. A 65-year-old female comes to the hospital in septic shock, and while telemetry monitoring, develops AFib for 5 minutes. And most of the time, the patient comes to me afterwards on anticoagulation, and I have to make a decision whether to continue anticoagulation or not. For the time being, I'm going to continue it, but then I'm going to do heart monitor, not on any antiarrhythmic. I will continue this at least for 2 to 3 months and sit down with the patient and discuss them. One option would be that I repeat another heart monitor and then stop it and make it very, very clear to the patient. Other thing that a lot of times, if the patient is a little higher risk, we put a loop recorder in. And then we stop anticoagulation and plan that if there is any recurrence of AFib on the loop recorder, we restart it. Because we cannot minimize the risk of bleeding with anticoagulation either.
One question, Rafique bhai. Yeah, if in the loop recorder, if the recurrence is like small, burden is small and very short run, like only a few seconds, like 10 seconds or less than around, and burden is like less than 1%. So this situation becomes a little bit difficult to make decision. But if the patient had a stroke already, we know that.
Very high.
Yeah, the problem is this, as it stands right now, that we don't distinguish between 1 time AFib and 10 times AFib because there is no study. Actually, I think Hopkins is doing a study. They are looking at atrial fibrillation burden and risk of stroke.
Yes.
Is there any difference? 1 time AFib, 0.01% burden, 10 minutes of AFib once a year versus AFib all the time versus every month has 10 minutes of AFib. So once that study comes out, it will give us a better answer.
Yeah, and that is very interesting question. So I don't know how much time we have, but I was trying to show a picture of a clinical presentation, same thing with troponin, right? So if the troponin is 2000, one thing, 2000 or 2, 4th generation troponin versus 5th generation, you just multiply by 1,000. So 50,000 troponin, honestly, you can only have 2 differential, myocarditis or frank MI. So it is very important that it is not just rule in, rule out. It is also the magnitude of the problem and the clinical context that takes you a lot. So maybe I just go, because we have only a few more minutes. Any idea what the diagnosis on this one? This patient had substance abuse, and then suddenly the left leg is basically non-viable. And the patient came in with this EKG. Left leg, no pulse, cold, clammy, and kidney function is bad. And they were worried that this patient may have a cardiac cause of emboli. Troponin became high. CPK was more than 100,000, lactate high. So basically this patient developed renal failure with high potassium giving this. We had other EKGs that can also be, you mentioned Tushar about the EKGs in ICU, and Adizbhai is going to address this. Sometimes you see potassium problem, hypokalemia related ST changes, and that can be compounded with with the drop in hemoglobin, and the routine use of troponin make it complicated. But one thing you can do to see the magnitude of the troponin: bedside echo, repeat EKG, correction of the lights, and then repeat the EKG. You will be surprised that how you can treat this patient. This is a 29-year-old with infection, and this EKG, they were concerned about the ischemia because of the T inversion, very symmetric T inversions in the precordial leads. And 29-year-old, it cannot be or unlikely to be coronary, maybe anomalous, but LV function normal, THS normal. Some patients, particularly females, can have persistent juvenile pattern in the EKG with the T inversions, and not to worry about that. And I will finish with the last few EKGs. And I showed this shark fin EKGs. These are very ugly looking, and this can be a real ST elevation MI, or it can be compounded with problems of metabolic derangement, hypoxia, acidosis, and hypokalemia, hyperkalemia. And this patient had this CT, small calcification, and we ended up finally, after the patient got stabilized and before discharge, there was some non-flow limiting stenosis, but nothing major. All happened when the EF was bad, septic, very sick, belly bad, abdominal catastrophe. But before the discharge, all these recovered and patient went home. But these patients usually do not survive because of this degree of ICU comorbidities in terms of metabolic derangements, underlying sepsis, or bowel ischemia, and other comorbidities. This is just a simple EKGs of, the lead transposition and dextrocardia. But one cautionary note: if his limb changes, please do not read ischemia in that EKG. Repeat and then read. However, sometimes you may be fooled. This is a patient with EKG changes, cabbage. You can call about pericarditis, but this is convex up and looks like tombstoning. And this patient indeed had a lima down, and we had to take this patient to the cath lab. But I'll finish with this one. This is interesting. This patient came in with white complex tachycardia. This looks like torsade. Then EKG thereafter was okay. And then we corrected this. EF was normal. And this patient was taking medications that caused prolonged QT. Sometimes if it is recurrent, you may need to put a temporary wire. In addition to giving magnesium, correction of potassium, you may need to overdrive pace to keep this patient out of this.
Hafiz, can you go back to that first
Yeah.
ECG with the torsade?
Yeah.
Yeah, sure.
Yeah.
We don't have any prior one at this QT was prolonged, but most likely.
Yeah. And is a purist, whether they prolong QT or not. That's like whether you call it polymorphic VT or full-blown torsade. But the issue is that if it is a clinical context suggestive of ischemia, then please go after ischemia and then correct the ischemia. So this patient, this was the EKG on admission, and then patient had seizure, carbamazepine and lamotrigine. EKG came to like this, And then patient in the night did this.
Just 1 second.
Patient was in ICU because of the seizure disorder, and ICU doctors got panic. So code blue, patient actually coded, and ultimately, I don't know, you may criticize us. We did do the coronaries are fine. I think it was long QT and torsade. And then I'm finishing with this one, 63-year-old, hypertension, dizziness, exertion, and then lightheaded, and then EKG, look at the PVC, and then this in the ER. So this was the PVC, and then this in the ER. So we call this monomorphic VT, and is it scar related, or is it outflow tract VT, or is it LVOT VT or RVOT VT? That raises question. However, we did the echo. Echo was good, but this patient had all the risk factors for coronaries. We ended up coronaries, and then this is a significant multivessel disease. So it is not always that polymorphic VT is because of ischemia, and monomorphic is always scar, but it can be overlap either way. But clinical context is very important. So
Thank you, sir. We
yeah.
are almost at our
Yeah.
time.
We'll stop there. So whatever it is, we need to go back to this, that in the ICU setting, it is the rhythm or tachybrady, or whether there is any underlying coronary issues or myocarditis. And then more importantly, another big heading is, am I dealing with electrolyte imbalance, hypoxia, acidosis? If you can keep these three areas in your mind in the ICU setting, I think vast majority of the cases you may be able to tackle very well. And then please do not feel intimidated. At least say this is tachycardia or bradycardia, regular, irregular. It is wide or narrow. And then is there any pattern? And what is the clinical context? And who is the patient? What are my differential? And then get a bedside echo and discuss with the colleagues.
Thank you for excellent ECGs, nice discussion, and moreover, the pointing out to the need of go back to clinical context. We should not only treat the ECG, we should treat the clinical context on which the ECGs were done. We are at the fag end of our presentation, and I'd like to request Professor Abdul Jamil sir to say about the presentation and conclude the session. Abdul Jamil sir. Jamil sir, are you with us?
Yes.
Okay. Sir, I'd like to request you to say some remark about, give your remark on this presentation and conclude the session.
Thank you. Thank you, Tushar. It was an excellent session with all interesting cases, EKGs, and their outcomes. And Hafiz Bhai is always present all interesting cases, and we learned a lot from him in every presentation. Thank you, Hafiz Bhai. And so I request Tushar to end the session. Thank you very much.
And I thank all the participants, because it's late in the night, and actually it makes it worth if you come and talk to us and attend, and together we learn.
Thank you. It was a good session. Thank you.
Thank you all. And our next presentation will be on the 26th of October, and it will be presented by Dr. Azizul Haq sir. And
I may not participate as I'll be in TCT.
Okay.
at that time.
Okay. So, as Hafiz sir said, we like to thank all our participants for joining the session and make it a lively one. And thank you, our scientific partner, Example Pharmaceuticals. Good night, all the participants, and we'll meet again on 26th October.
Thank you.
Good night. Allah Hafiz. Assalamu alaikum.